for action now and throughout the presentation. I'm happy to be interrupted, keep it interactive, and there'll be plenty of time at the end to discuss things as well. And I think it might be useful to see where you are and what would be useful for you. So I'm going to talk through some of the most interesting data on this subject, and then we can do some breakout rooms, maybe do some troubleshooting and plan some future work. So I've been working for about 3 years on interactions between health and climate, and I'm going to start with a confession that I've got a 2-litre, 13-year-old petrol estate car, so you don't think I'm pretending to do things perfectly, because that's not really the way forward. We can't have a few people doing things perfectly. We need all of us doing things imperfectly. I'm motivated by a combination of connection with nature, a bit of ecological grief, a bit of climate anxiety and flygskam, which is the Swedish for flight shame, an interest in having an impact, and an interest in practicing evidence-based medicine. And following the evidence has led me to want to work on environmental issues because they are the biggest health risk this century. And that's one of 4 perspectives as to why I think this is relevant to primary care. So the first one is the impact of climate change on human health, and you'll probably know this stuff quite well. That's for another presentation another time. I'll save all the bad news for someone else, and I'm going to try and focus on the positive stuff. So the second reason I'm interested in health and how they interact is that primary care is responsible for about 1/4 of healthcare emissions, and healthcare emissions are responsible for about 5.4% of global emissions. So what we do is a big part of this as well. And of course, we want to do no harm, but we are doing harm. The third perspective as to why I think this is relevant to us is that we are consistently the trusted professionals, the trusted messengers of science. In the UK, it's nurses and doctors consistently at the top. Globally, it tends to be doctors at the top of the most trusted professionals. So with the widespread behavioural change that's needed, people are looking to us to both communicate this, but probably also lead on it as well. So I think there's scope for us to do a bit more there. And then the fourth way that I'm interested in this subject, and that's why this is the bulk of tonight's talk, is the potential benefits. So the potential benefits of, if we have climate action, what healthcare improvements can we see? And there's a lot of scope for improving the health of problems that have been very difficult in Scotland for a very long time, Scotland and the UK. So the opportunities from mitigating climate change, so reducing our emissions, is the main focus tonight. And the scientifically plausible, possible outcome of improved outcomes rather than just all the negative outcomes. So I'm not going to talk about the dangers of inaction, that's widely available elsewhere, but yeah, realistic opportunities for improvement is the focus tonight. I'm happy to be interrupted, but I can't, let's see if I can get the chat bit open here. A bit of muffling on my sound. Is it any better now?
Yeah, it's generally good. It's just, it sounds as though, I don't know, maybe something rubbing against your mic anywhere. It's very intermittent.
Intermittent. I'm afraid there's not. I'm not sure what I can do about that other than put a headset on. Maybe if you're having difficulty hearing me, I'll go and get a headset. But will I carry on for now?
Yeah, keep going.
Okay. So yeah, this is a busy slide, which I'll try and break down and pick out the most interesting bits. On the left-hand side there, you've got interventions, and along the bottom are the health benefits. But if we're looking at it from a point of view of cutting emissions and how that can improve health, then let's have a look at the emissions by sector in the UK. So transport, energy supply, business, residential, these are the big 4 there. So we'll focus on these, on that really. And if we break it down by UK citizens, breaks it down into nice quarters there. We've got food, housing, travel, and everything else, which is kind of the stuff we consume and buy. So fuel poverty, I think, is as good a place to start as anywhere. Heating our home really is about 1/4 of our individual carbon footprints. And whether you have fuel poverty or not, this is relevant. The heating of your home and the energy use on that, and the ventilation of your home because of indoor air pollution as well. But basically, very strong links between poorly heated homes and ill health. These go together very strongly, and warm homes reduce ill health. So there's a review of 29 studies from Geriatric Medicine Journal by Eden Lackesing, James Johnson, 2019 for most of the figures used here. And the government estimate of how many people are in fuel poverty was about 13% in England before pandemic. And the latest figures published in the BMJ in recent weeks suggest 25% of people in Scotland live in fuel poverty. So they can't afford to heat their home to the adequate level. And that has been defined as 18 degrees is the lowest that could be considered as a comfortable temperature. So fuel poverty depends on three interacting figures: household income, energy efficiency, and fuel prices. And while there's a link with deprivation in general, it's not entirely a linear one, because you could have an individual or family with a reasonable income living in a very energy inefficient home who may slip into fuel poverty. So in international terms, the UK performs very poorly in this domain compared to most other developed countries, especially Scandinavian countries, mostly because of thermal inefficiency of the UK housing stock. And so these countries with colder winters have a long history of very much more fuel efficient design. And also in the UK, we have worse socioeconomic extremes which will affect it. So poor home efficiency costs money, causes a big quarter of individual emissions, and it's a major health issue, which I'm going to go into in a bit more detail here. So starting off with cardiovascular, it's well recognized that mortality from both heart disease and cerebrovascular disease is more likely in cold temperatures. The explanation for this, the studies showing that a 1 degree centigrade lowering of room temperature raises blood pressure by 1.3 millimeters of mercury. The neurohumoral catecholamine code in response to cold, I like that one. That basically the interaction between nerves and hormones lead to progressive peripheral vasoconstriction in a bid to preserve core body temperature. So another important contribution to the cardiovascular mortality, as well as the blood pressure I just mentioned there, is the thrombogenic effect of raised plasma fibrinogen and factor 7 levels. And also there is an increased immune response to increased respiratory tract infections, which will increase the risk of cardiovascular events. A study from Scotland showed that cold could be a significant factor in the total burden of hypertensive disease. Shuey and Shuey calculated that 9% of hypertensive burden was due to indoor temperatures of less than 18 degrees. Cold and damp linked to significant respiratory disease, especially the more extreme temperatures. And if you're below 5 degrees, then every time you go down a further degree, you're increasing your risk of a respiratory tract infection by 19%. And a GP consultation that goes along with that, of course. The warm front evaluation study showed a 50% reduction in anxiety and depression symptoms when the bedroom temperature increased from 15 to 21 degrees. 50% reduction, so that's absolutely huge. So mental health is significant, but there's other examples as well, like hip fractures, diabetes complications, ulcers, osteoarthritis, general frailty. So this is an expensive problem, and it was estimated in England it would cost about 35 to 65 billion to retrofit the housing stock. And that picture is the end of a terrace where one of the buildings has been retrofitted to be properly insulated. But a rather pessimistic estimate suggests that 1.4 billion of savings per year would be to the NHS would be gained by doing this. So it would pay itself off. And that's, I guess, even before you consider the cost of inaction, which is probably fairly infinite if we all go extinct. So that's the fuel poverty side of things, and there's some pretty major benefits to the health if we properly insulate our housing stock. And I guess for us as GPs, that's trying to find out who these people are, referring to social prescribers or council to work out who's at risk of fuel poverty. But ultimately, it needs national intervention to retrofit homes, particularly focusing on the poorest and the worst housing stock. So the next big one is diet. Now, food and its associated impacts count for about a third of the global carbon footprint. Especially bad are the ruminants, so that's cattle and sheep in particular. But also this is partly due to deforestation, transportation, and that contributes to high emissions. That's not to mention the loss of habitats, loss of biodiversity, increased risk of pandemics. And so there's a solution being proposed by the Lancet EAT Commission, co-chaired by Walter Willett and Johan Rockström. And that brings together 19 commissioners, 18 co-authors from 16 countries in various fields, including human health, agriculture, political science, environmental sustainability. So global food production threatens climate stability and ecosystem resilience, and it constitutes the single largest driver of environmental degradation and transgression of planetary boundaries. So you probably have heard that we consume more than the planet can sustain, and this is one of the main ways that we're doing that is food in our food systems. So really we need a pretty radical transformation of our global food system, and the aim of the Lancet Commission was to show how to do that, what would improve health and have a healthy planet. Interestingly, the existing guides don't really consider sustainability like the Eat Well guide in the UK, but if people stuck to the Eat Well guide in the UK, that would reduce emissions by about 20%, because a healthy diet tends to align with an environmentally sustainable diet, thankfully. So the need is clear, but the benefits are also huge. And if we got this transformation of the global diet, that could prevent 11 million deaths a year. Now, that would also reduce the emissions from 19 gigatons down to 5 gigatons, or nearly a quarter of global emissions each year. So what is this diet? What is the diet that has been suggested? So it would be roughly 50% fruit and veg. This is a summary here, but more specific in the literature. There are examples depending on where you are in the world and what's available locally. But largely it's a shift of 50% less red meat, dairy, processed meat, sugar, starch, and too much oil, and increasing global consumption of fruits, vegetables, nuts, and legumes by about, well, doubling them really. So a diet rich in these plant-based foods with fewer animal source of proteins confers both health and environmental benefits, including reduced cancer, reduced heart disease, obesity, diabetes, better mental health. And for example, for our Western diet, it would reduce the risk of premature death by 20%. So pretty major stuff here. And I guess what I do in practice now is I don't necessarily really mention the climate, but this is just the diet that I talk about when patients are looking for suggestions, and it's always good to be able to suggest more of what people can eat rather than telling them to cut things. So moving on to travel, about a quarter of a UK citizen's carbon footprint. Travel is big for the carbon and carbon dioxide equivalent emissions, but also the air pollution. So, for example, about a third of nitrogen oxides and a lot of the particulate matter, which is responsible for what's estimated to be about 3,000 deaths a year in Scotland. And also linked to travel and transport and the emissions from current travel systems is the inactivity, and physical inactivity kills in the UK about every 15 minutes. So what we're talking about here is if we reduce emissions from transport, shift to active travel, we can improve health, reduce hospital presentations, reduce GP presentations. And it's probably the closest thing to a silver bullet we have is increasing exercise, as you'll know. These are some of the many benefits, but I won't preach to the experts on this stuff. But there's robust data from Stephen Blair about fitness being the strongest predictor of mortality, reducing the risk of dementia, all of these things that I'm sure you know well, but there's useful resources on that. But probably in summary, the best thing you can do for health is be active for 30 to 60 minutes a day, or if you look at it another way, could you cut your sitting and sleeping to just 23.5 hours a day, or can you do your home visits like this? And thinking of how we can fit this into the patients' lives as well. But wouldn't it be great if we used travel to improve health rather than harm it? It's estimated that a mile driven in a petrol car or a diesel car around a built-up area shortens life by about 6 minutes in that area. So the home visits we do are causing harm. So we know that transport is a big carbon and air pollution emitter, and health reasons for cutting it. And we've discussed the benefits of shifting to being more active. We also know that people would use more active travel if they felt it was safe and convenient. So that means being segregated from traffic rather than just dotted advisory lines. Direct routes rather than circuitous routes that prioritise cars. Infrastructure at destinations like secure places to lock bikes, showers at work, these sorts of things. The other thing to consider is we can't just shift from petrol cars to electric cars because they've got significant particulate matter from brake dust and tyre wear. There's a study actually out this week showing that tyre wear is worse than exhaust emissions for particulate matter. So not for carbon dioxide and the atmosphere, but for the actual particles that cause the air pollution, that cause these air pollution deaths. So electric cars being heavier will have more tyre wear, more emissions. So there's a significant problem from everyone shifting to an electric car. It's obviously far inferior to everyone walking, wheeling, cycling, running. Okay, so the next thing we'll talk about is the green and blue space, and you're probably getting more and more information about green prescribing. It's pretty patchy. The services we've got at the moment, I think realistically, are not as easy to use as prescribing a medication or referring to other services, and that's something that there's work on nationally to try and improve. But looking at green or blue spaces from a climate point of view, we need healthy green and blue spaces for capturing carbon, for biodiversity, for adaptation, for the climate changes that we're going to have, such as increased flooding risks in Scotland. But there's also huge benefits to our health from greater access to nature. There's a study by Matthew White et al. In 2019, referencing 59 studies published in Nature, and I've picked some of the best bits. I mean, this is stuff we've known about since in the 80s in Japan. They talk about forest bathing there, but this is a newer review I'm going to have a look at. So we know that exposure to space that is green or vegetation or blue, such as meaning water courses, reduces stress hormones like cortisol, of course linked to blood pressure, mental health, and many chronic diseases, cardiovascular diseases especially. And simply time spent in nature can improve sleep, boost the immune system. That's quite an interesting one because it comes from the phytoncides, which are released by plants as defense mechanisms to prevent them getting infections. Phytoncide meaning exterminated by the plant. These are volatile organic compounds that protect the plant from bacteria, fungi, and they're probably the smells of nature that we breathe in, and these compounds stimulate our immune system, which reduces our susceptibility to infectious diseases. And there's some early studies, it's too early for us to be sure, but they think that it may have a preventative effect on cancer as well. So yeah, time spent in nature can also be helpful for calming behavior. It can help symptoms of ADHD. It's quite strongly enough evidence-based for us to suggest that to the massive tsunami of people presenting with ADHD, that spending time in nature is an evidence-based intervention for that. It's been shown to improve memory. There's evidence too that greener schools have higher test scores, even adjusting for family income. So time in green and blue space, whether you're particularly engaged with it and getting all the other benefits of it, can be very important for our health. So my final comment on how climate mitigation can improve the environment, improve health, is through connection to nature and one another. There's a 2019 paper by Bratman et al. Discussing how nature experience is also associated with increased social cohesion, resilience, sense of purpose. And I'm sure you'll all have seen plenty of people who have mental health issues who have a real lack of these things. So it requires a shift away from viewing yourself as separate to nature or in opposition to nature, as much of Western culture has historically been. A shift towards realizing that we are part of it, we are indisputably connected to nature, And there's great research, which I think links nicely to this, from Scotland in 2017, from Fabio Cientani, published by a British Psychological Society, which shows how our identification with other groups or tribes is a very strong predictor of mental health. So if you identify with fewer groups, like family, community, social groups, that's a much more severe predictor of poor mental health than even deprivation, which of course we know is major. And I guess, and the other side of that is, if you're strongly connected to 4 or more groups, then you have almost no chance of having significant mental health. If you have very close, say, family, work group, club, and something else, if you have lots of very good support networks. So I guess as a GP, you'll probably see daily the effect of isolation and living alone on mental health. So there's a good opportunity here, and there's some great pilots going on showing that if these lonely people are able to connect with one another and with nature over a shared interest, then that can have a really, really good impact. And we'll all be well familiar with how important to people the sense of tribe is. I'm sure we see every day how much people feel they need to be connected to something. But connection with nature offers benefits in its own right. So that's the biophilia hypothesis. But it also gives the chance to connect with one another, being a strong predictor of mental health and well-being. So why don't people act? I don't have the original source for this slide, so I can't tell you how reliable it is, but at least it gives us some ideas as to maybe what's holding people back and what's holding people back with action. You'll be so you'll be familiar with these sorts of things. So why don't people? If we start at the first one there, people don't think it's happening. So I guess what we need to come back to there is, well, who are they going to listen to? Who are they going to trust? And that's the trusted professionals. That's us, healthcare workers. So we really need to be talking about this stuff. People don't think it's relevant. Well, I guess that's why we need to talk about it in terms of what's local. We're going to have increased flooding, increased extreme weather. There's projections that we'll quite soon have cholera in the waters around Scotland. Ticks are now being found to survive all year round in Scotland, so increased tick-borne diseases. So I guess we need to talk about why it's relevant, but we also need to talk about it in positive terms, because people don't like talking about scary things. So that's why I like to talk about the benefits of, if we get this stuff right, how we can speed up change and improve things. The next one is people don't know what to do about it. And I guess probably there, just getting started on something is key, whether that's in your personal life or particularly for this stuff in your practice and how you talk to patients. Accepting that probably imperfect action is better than inaction. And then people don't like feeling guilty. I guess you can use that guilt to try and motivate people to do things, but there's probably a lot to be gained by feeling part of the solution rather than part of the problem, and that was how I would turn that one round. Not thinking other people care, and I guess that comes back to the importance of being visible that people do care and are doing things about this. So, conclusion to the first part here, before we go into discuss things and whatever you want to talk about, achieving net zero emissions has the potential to significantly benefit health through improved home standards, better diets, improved air quality, increased physical activity, but also I think through access to green spaces, more and more evidence is showing. The key thing here is considering health equity in all policies and all actions, and those who are currently most disadvantaged and most vulnerable have the opportunity to benefit the most. And of course, I think something that's really interesting here is how, of course, this is to reduce illness, but that could also reduce GP presentations. And we're a bit short of ideas as to how to cope with ever increasing demand and decreasing number of GPs. But I think this is a pretty good way of doing that if we reduce the demand on the service that way. And we know that our health depends on planetary health as well. So I've tried to pick out some of the key bits of data and useful summaries here to demonstrate the big benefits of health climate change. And I guess what I'd be interested to do now is maybe have a bit of a discussion as to any questions about this presentation. any questions about things that you're trying to do, barriers that you've come up against, things that you'd like to see me, my colleagues and the college doing more in this field, and I can talk to you a bit more about what we are doing. I guess I'm trying to focus on removing the barriers to people acting. So if you want a kind of bottom-up approach, then very often I'll have conversations with people who start trying to do things, and very quickly there's all sorts of things getting in their way. So we're trying to get things out of their way, we're trying to get time and funding to help people make the changes in how they practice and their buildings, trying to get national guidance that considers this stuff so that it's easy for GPs to use, because the last thing I want to do is create more tasks for overworked GPs. But that's enough from me, and it'd be great to see what your thoughts are on this and other things, and maybe we could do some troubleshooting or planning as to what else would be useful for you. Cheers, folks. What I can maybe do is tell you about some of the work that has been ongoing in the background, because otherwise you might not know. But yeah, please send any questions in, or just start chatting, or raise your hand or whatever. Oh, Galessa, I see you've got your hand up. Go for it. Hiya.
Yes, hello. Thank you. That was really interesting. And you mentioned about how we're sort of not doing or we're contributing in terms of home visits, and I wondered if you had any ideas in terms of solutions.
Yeah, so I have started doing home visits by e-bike. Tomorrow is my first day doing a duty doc day on call with just the e-bike, so I'm a little bit nervous if I have to go from the far west of Invergowrie to east of Monifieth in 2 consecutive visits on my e-bike. That'll be not very well. It's actually, sometimes it's quicker on e-bike, sometimes it's a bit slower. That will probably be a bit slower. So yeah, what I've been trying to do is get a bit of clear funding streams for that, and there are funding streams for e-bikes for GPs. Not everyone's going to be comfortable doing that, so probably a realistic way forward would be e-bikes for near visits if you're able, and an electric car for the next vehicle you purchase for the practice for further away visits. I guess that's probably the best solution I can think of. The other thing that I'd like to see from all sorts of perspectives is sorting out the boundaries of practices. It's not going to be popular, but there's all sorts of problems around the country where you've got historic boundaries, and that means it's inefficient. And I think that's perhaps a controversial one, but I would suggest we need to look at the boundaries being improved as well. Don't know what your thoughts are on this.
No, I didn't really have a solution. It's just that I had encountered this issue in terms of like either cycling or getting the bus to locum work, for example, and then not always being able to do visits if they weren't within, walking distance or cycling distance.
Yeah, I think we need to change how we do that. James.
Hi guys, I'm James. I don't really know any of you, I don't think. I just got the email. I'm a GP in Glasgow, and just to reassure you, Munro, I've been doing home visits and commuting by an electric cargo bike for the last 1.5 years, and it is awesome.
Nice one.
It's in a rough, if anyone's worried about being sweaty, you don't really get it, because it's a rough equivalent to walking to work, I think. And I think it's a good thing. It's good to be visible. Park outside the front of the surgery. It's a good. I think you're right in terms of we're limited in what we can actually do, in terms of insulating old surgeries. Yeah, it'd be great. Driving electric cars, yeah, it'd be great. But it doesn't actually reduce overall emissions that much. But what we can do is lead by example and green prescribe and do all these other things to encourage other people. So yeah, I really enjoyed that. Thank you.
Thanks very much, James. We've actually got a meeting with civil servants in the next couple of weeks about how we can try and make it easy for premises to access changes, because yeah, that's just a part of the emissions, but it's quite difficult with all the different types of premises. So that's something else we're trying to do. There's a question in the box there. GP surgery insurance for bikes. One of the limiting factors to our surgery getting one. Yeah, I've got my own bike, so I'm not sure the answer to that. So, Deepa, do you want to tell us a bit more about the problem you had there?
Yeah, hi, I'm Deepa. I'm one of the GPs working up in Shetland, and we've been really lucky to have e-bikes that the health board have got. But the surgery that I work in is an independent practice, and we've been told that one of the limiting factors is they can't sort out the insurance for the surgery to have an e-bike, even though the funding is there. Just, yeah, I think it's because of as an institution to get out insurance with people using it. I don't know if anyone else has figured out how to get past that.
Okay, I don't know if James has got experience of that, but I know there's a few practices around who are using e-bikes all the time, so I can try and get in touch with them and find out if they've got any solutions. Yeah, these are the sort of things I want to hear about, so problems I didn't know existed.
Sounds like it should be covered by your public liability insurance and your employer's liability insurance, and equally the bike insurance itself. The practice, if it's an independent contractor, could sign up for the British Cycling insurance scheme, which covers you third party, say if you hit a pedestrian or hit a car or something. And I think they do a business insurance. So I would have a look at the British Cycling insurance.
Fab, thank you. Actually, that might be really useful. But yeah, we've got an active travel person employed with the NHS, and she's been struggling to figure it out. So it'll be useful to have a look.
That's really useful. Thanks, James. Yeah, British Cycling and Cycling UK are the other one to do that third party thing. Any other? Oh yeah, Alika, you've got your hand up there.
This was a question for James, actually, just because I'm interested in how long you've been managing to use your e-bike, and therefore the discussions around how visible you've been, whether people at the practice have commented on it, your patients, because I think really, you know, this is the whole message, isn't it? It's that this is achievable. So if you've managed to do it for 18 months, then, you know, that's the standard that I would like to set for all of us. It can be done.
Okay, so it was a decision I made when I was in quite a rural practice, and actually covering quite a large geographical area, and still it was faster than driving, because when you figure out all the issues with parking, with you know, finding the place, when you're even just going out of the surgery, you can just jump on the bike and go. It's it's just much faster. And then in the city now that I'm in a city practice in Glasgow, it is absolutely night and day, way faster, even with our historic patients who have managed to cling on despite being well out of our current boundary. I built it myself, so it did take quite a long while, and it was a bit cheaper. If you buy one of these off the shelf, these cargo bikes, electric cargo bikes that have got space for a bag and stuff at the front, they're about $5 grand, whereas this cost about $3, but it's all tax deductible, and it would, you know, this can all come off the tax. It's all tax deductible if you're a practice expense as well if you're partners. It's very visible. It says "Doctor on call" down the side of it. Park it out front of the surgery, as I say, and yes, you get comments all the time. I've never had a negative comment. The only thing is you have to be careful about the language you use as people brush past you in their cars doing about 90 miles an hour in a 30, because you're very visible, obviously.
Brilliant. Thanks for sharing that, James. Good on you. Deepa.
Yeah, I was just going to say, so we've set up a greener practice group up in Grampian, and actually at the moment, the main participants are people in Shetland, including James's mum, who's been brilliant actually as one of the GPs, who's really inspired us with all the sort of greening that she's done at her surgery. But one of the things I guess I feel like we're struggling is when we're thinking about what we're going to be doing, is that I feel like we're trying to reinvent the wheel here a little bit and starting again. So we've been looking at our inhalers prescribing and trying to change our guidance. And I guess it'd be really good to be linked in with other groups across Scotland that are probably doing similar work, so that we could share a little bit more, but I'm not, yeah, it'd be good to know what else is going on. And I'm sure there's loads of other great ideas with, increasing sort of nature and health interventions, thinking about like all the active travel things. But I feel like we're kind of starting on our own, and because we're a small group of people and people's time's quite limited, it'd be lovely to kind of have a way of sharing ideas of what's happening a bit easier throughout Scotland.
Yeah, I think probably the Greener Practice Network's the best way to do that. And they've already got resources, and I think you can join WhatsApp groups as well. Maybe we should get I think the danger is anytime you have a group, a Slack chat or Google group, it just creates more emails and more things to check, and it's trying to find something that's useful without creating extra work. I'm not sure the answer to that, to sharing stuff, but I guess I'm always happy to be contacted, and I think as college leads in the different areas, we can maybe coordinate a bit as well. But yeah, I'm not sure the solution to that one. I think there's a question in there from David Stevens. Team lead appraiser for NHS Highland. We've been doing Teams appraisal. Shall we go back to face-to-face? Yeah, I guess when it comes to, if it's a patient consultation, should we go back to face-to-face, then I would say, well, you do what's best for the patient, and part of the consideration might be the carbon footprint. And I guess I'd probably say the same thing for, I'd be interested to hear what everyone else thinks, but I'd say the same thing for appraisals, what's best for the person being appraised. I think for me, I'd probably rather have face-to-face. I don't know what everyone else thinks. I guess it depends on all sorts of factors. David, your microphone's not working, but you could perhaps put some of your thoughts in there as to what your thoughts are. Electronic prescribing, yeah, that is something that is embarrassingly slow in Scotland because we're way behind England now. There's all sorts of different angles for trying to put pressure on that: cost, efficiency, carbon footprint, all sorts of things. Yeah, it's a bit of an embarrassment, I think. So I guess what's going to influence things to speed up, because we know things can go more anti-hackers on the clinical advisory group for this and moving it forwards. Yeah, there's folk like yourselves have been pushing this for an awful long time. We know things can change quickly when they need to, like with the COVID pandemic. All sorts of things happen rapidly. So I think there's a bit of tardiness somewhere in the system, just stopping people like Anthony getting this moved on. Anthony, you can come in and tell us how we're getting on with this, perhaps. You're probably having your tea and doing 1,000 other things.
Hello, can you hear me?
Yeah.
Hi. So I'm Anthony Agger, GP in St Andrews. So I've managed to force my way onto the clinical advisory group, which wasn't easy. There's a fairly big Scottish project now ongoing with electronic prescribing. I'm amazed at the barriers, actually. I thought it was just something that you could just do. There's all sorts of problems in terms of electronic signatures, controlled drugs, the paper being used in the actual pharmacies. It's amazing how much they need the paper to actually administer and sort of divide up the drugs. But they're involved in the project as well, and there's a massive willingness to get it done. And the Scottish Government has put money and resource into it, and there is a national project now ongoing, and it feels like it's going to happen. It's also tied into the new EMIS vision procurement, so that they need to be kind of on board and a part of it as well. But I think that it will happen. I think probably next year we'll see the start potentially later this year. You'll start getting information out to the surgeries and things, just tell people how far we've got. I'm meeting every 6 to 8 weeks. Haven't really done anything apart from encourage them not to create an electronic signature which replaces our kind of very quick manual signature with a click of a mouse and a code, which is one of the dangers. So instead of signing 100 repeats in a couple of minutes, we'll be having to click mouse buttons, and it will be very inefficient. And that's been one of the battles, because I think there is a worry about safety, but in actual fact, signature is no longer a safety part of the system. So that's something that I've had to work on, because there is a bit of a sort of, right, let's swap that signature with a click box and a code. We also have to make sure that we're logging into the computers and we can identify who's logged into the computer. So that's another of these kind of unknown barriers that I didn't know was there. But it is happening, and it's a big project, and hopefully we will see paper disappear next year, and at which point I will get rid of my printer.
That's great. Thanks for coming in with the update there, Anthony. I see Joshua's got his hand up.
Hi, thank you very much. Super interesting. I hope you can hear me. My computer's sometimes a bit dodgy. I'm a GP trainee, GPST1 in Cornwall. So forgive me for some slightly vaguer questions. I guess maybe one of the barriers that I'm coming up against is partly related to the fact that I'm in training, so finding it a bit more difficult to get involved in specific places because I'm constantly on the move. Yeah, so I guess just sort of wondering, well, I'm trying to use that to my advantage by sort of getting in with the Cornwall Trust as well. But I guess if you just was just looking for any general advice on either particular projects or topics which you think are good to approach GP practices when I'm a trainee there for 6 months, and any approaches to stop me coming across as a sort of nagging trainee in the corner. And again, any advice on experiences dealing with the bigger trust and sort of bigger projects that might be good to kind of start with, and trying to ways to try and get them to stick to commitments, which they've seemingly been quite good at down here with net zero commitments in 2030. So yeah, sorry, a few sort of generic questions.
No, that's really useful to come in on that, because I mean, ultimately, all of this stuff is a human problem. It's not climate science, it's behavioral science, because it's how do we get people to be interested, to change behavior and things. And I'm actually doing a session on this at the RCGP conference in June about how influencing the wider system and lessons from greener practice. And the main theme that I'm going to be looking at is the parallels between being a GP and doing this. So you need the same GP consultation skills. It's all the same stuff. And if you wanted to change behavior with the patient, we know that just lecturing them doesn't work. Having done a half an hour lecture there, but at least I've got insight. No, but what it is, it's speaking to the stakeholders, having conversations with them, seeing where they are, what their thoughts are, what are their barriers, and asking how you can be of help to them, what would be useful for them, showing them what you care about, sharing the information if they're interested. And that would be my first bit of advice, is looking at how you can collaborate, proper listening, and I think that goes a long way, because as you say, you don't want to rub people up the wrong way. And I always think that if you do, then you're getting us further away from the solution, because you're alienating people, and we need everyone to be working on this stuff for health, etc. So that's probably the main message. I guess as more specific things would be finding who your RCGP local climate lead is, finding out if there's a greener practice group, linking in with greener practice nationally to make contacts. People who have done presentations will be happy to share their stuff and help you do a presentation to each practice you go to. The Green Impact for Health Toolkit, for example, you could do a bit of a talk on that, offer to do a bit of work and show that a few interventions can save the practice several £1,000s a year. I guess it depends what motivates people. You want to find out what they're interested in and let that guide it as well. So hopefully that gives you a few things to have a look at, but happy for you to get in touch with me and we can chat about it in more depth. I see there's a few questions. Okay, thanks, Joshua. I see there's a few questions down the side here. People working on inhalers, yeah, I tried to do that in Tayside, but making slow progress, so I'm trying to work on it nationally instead. And I guess the key things for inhalers, because inhalers are 3.2% of the whole NHS carbon footprint, probably the biggest individual part. The key things are just making sure, whenever you're communicating this stuff, that good asthma care has a lower carbon footprint, and always making sure that we're talking about prioritising care, because if people start thinking that our priority is planetary health instead of human health, when of course it's not, then that will alienate folk. Other things that people are working on, I guess, buildings, trying to get the buildings more efficient. I think there was a question about insulating. Am I right that in Scotland there's an NHS sustainability plan emerging, health boards having to write their local response to, including insulating buildings? Yeah, so the NHS sustainability plan is coming out in summer. We put in a big response to that, a big submission to that, and we're still kind of doing a bit of advocacy work to try and make that as strong as it can be before it comes out. Health boards do now have to report and have a plan. The difficulty being with general practices is you might have privately owned, you might have privately leased, you might have health board premises, there's all different types of setup, and each of them would have a different funding stream for insulating your practice. So that, yeah, as I say, that's something we're going to meet the civil servants about in the coming weeks to try and streamline that, because that's going to be we want that to be part of NHS net zero. Other questions? Green fund for old surgeries to insulate. Yeah, I mean, currently, James, there is, if you get in touch with Energy Savings Trust, small to medium enterprises, GP surgeries count as small to medium enterprises, so you can get business grants and business loans. So that is how to do it if you own your own building. If it's a health board building, then you have to, I guess, work with your health board there. And if you're in the situation that we are in our practice of waiting to be taken over by the health board, then what we're trying to do is get the health board to agree to take on any loans, so that you're not paying power plus loans. But yeah, Energy Savings Trust, they will do an energy assessment of your property and give you advice as to what would be the best things to do. It used to be done by Zero Waste Scotland, but it's just been moved over. Let's see what else we've got. Waste management. Yeah, let's see. Anyone got any top tips for trying to improve waste and recycling at their surgery? That's been another struggle where I work. Anyone done better than me? Probably wouldn't be hard. Got a message down here. That's appraisals. Come back to that. Yeah, I don't have any good answers about waste, but Alika, you got your hand up there, sorry.
I don't have any answers, but I can share with you the problems that we've had, which is that we're in a practice just outside Edinburgh, so we're in Midlothian. So Edinburgh has access to Changeworks, who are this amazing organisation that can deal with recycling across local businesses, and they work with practices within Edinburgh. But because we're outside Edinburgh, we don't have access to their fantastic services, and we approached our local HSCP, who've refused to fund recycling. So we don't currently have any recycling that happens at our practice. We've got all the bins, and we diligently put recycling into the appropriate bins, but it's not dealt with in any way at all. So it just gets put into the normal black bag bin, essentially. So I know that there's been lots of really excellent work that's happened in England on better waste segregation of clinical waste. And Munro, you might know more about this than me, about what needs to get incinerated and tiger stripe bins and all this sort of stuff, which Scotland isn't doing much on at the moment, as far as I'm aware. So I don't know if we've got a lot to learn from England on actually how we deal with non-infectious clinical waste in our practices that don't require the orange bins that we have. But yeah, there's this whole question around what should just go in black bin bag, what needs to go in incinerated orange bag at huge temperatures, what can go in a tiger bag, which is probably the majority of what we deal with in general practice, and then the whole question of recycling. So I think there's lots of scope for work here, and I imagine that secondary care and the hospital environment have probably done a lot of this work already. It's just how we extrapolate that to primary care.
Yeah, I'm meeting with our infection control nurses for the many secondary and primary care on Friday to start, I guess, chatting it through. But it feels that a lot of the information out there is aimed more at secondary care than primary care about what we should do with our waste. And to be really nice to have something that's a bit easier to use for primary care settings.
Thank you both. So there's a useful link on the inhalers there, and there's also a really good toolkit on the Greener Practice National page. Coming back to appraisals, thanks for that, David. Yeah, I guess probably as we've tried to do with the college, having an environmental consideration is maybe the best answer to that, because as long as you're considering it, I think that's progress, and it'll be different for different people, different situations. As you say, the travel options are there, but I guess a bit like general practice, it's nice to have a bit of autonomy as well, and not to have everything nationally dictated, and to work out what works for you best and be trusted to make that decision, as long as we're considering the environmental issues. But that's just one opinion. Okay, any other thoughts or questions at the moment? We did have a very good meeting with the Royal Pharmaceutical Society and a few other Royal Colleges and the Royal Academy, talking about prescribing, because prescribing is about 60% of the GP's carbon footprint, and there's all sorts of different streams to that work. Because, and coming back to the waste there, the currently medications, the excretion of them is part of the waste, but also a lot of people just throw them out or flush them down the loo, or there's also the waste involved in producing medications. So if medications should be returned to the pharmacy to be incinerated to avoid them being flushed down the loo. Especially inhalers, it's better that, even though the inhalers could be recycled and they're not being recycled at the moment, it's still better for them to be incinerated than for the greenhouse gases to be released, the propellants to be released. Yeah, let me get Deepa, you can come in there, and then I'm going to give you a bit of an update on the action, other stuff we've been doing at the college.
Yeah. And just going back to thinking about nature and health interventions. So the GP surgery and the care home that I work in are sort of next to each other, and they're really keen to try and start up a gardening group for care home residents, sort of daycare residents, and members of the community to come to. But one of the stumbling blocks over pre-pandemic was them accessing funding to try and get this going. And I guess, are there sort of streams of healthcare NHS funding that we can apply to for, pots of money of a few thousand pounds to try and help set up projects? And where do we find out about things like that, if they are?
Short answer is I don't know. I don't know if other people know of particular funding streams. Looks like no one else does either. I'm actually looking for funding for a couple of things at the moment. Not even that one. So there's the SVCO Funding Scotland. There's this database of different funding streams. I guess I guess what I would like to do with green prescribing is get a sign guidance, get a proper robust bit of evidence that GPs are just so confident and comfortable using, and then having that resourced with an easy to use system that's just as easy as prescribing medication, just as easy as doing a referral, because currently it's not. There's evidence about to come out from Glasgow, from Sebastian Chaston at Glasgow Cali Uni, showing huge financial savings from green prescribing interventions for mental health, much reducing use of antidepressants, improving outcomes. So this is local data that will hopefully help us ask for this stuff nationally. I'll just put the link in there for the premises assessments for business and things, for practices. Okay, I can whiz through some of the stuff that we've been doing. We've got an action plan. One of the things was moving away from e-paper prescribing, and that we've had an update on that, but we're continuing to call for that through the college asking MSPs. And there's a joint statement coming out from the event from the Royal Pharmaceutical Society about all the things we can do about prescribing. What else have we been doing? Yeah, we're going to try and speak to sign guidance, because they did put in environmental considerations with their asthma and BTS things, and we basically said, can you do that with everything? And it'd be nice to have a green prescribing guidance as well. Yeah, we put in a fairly robust response to the NHS sustainability strategy. What else are we doing? What have we got here? An event, active practice charter, focused on behavioural practices. Oh yeah. Yeah, that would be useful to share that.
Yeah, that was just in response to Deepa's last question. I don't know if it will have direct links to funding that would be suitable, but it may be another avenue to look into. So I'll take that out.
David, that's great. I think I was waiting for the secretariat at the college to make links with sign on this, but if you can raise it at your next meeting, that would be really lovely. We did mention it to, I've forgotten her name, Timony, isn't it? Angela Timony, I think it was. We did mention to that at the at one of the Scottish Council meetings as well, so she is aware of the thoughts on this, but that would be great if you could raise this, because that's the feedback we're getting from GPs, and I would feed that back too. Is we want the same level of robust evidence for green prescribing as there is for all the other interventions we do, and if it could be embedded in all the guidance as to, like, ideally what we're looking for is the triple bottom line, so you're not just looking at patient outcomes versus cost, it's patient outcomes against cost, environmental and social outcomes as well, considerations. There we go. There's some funding. We need another GP rep on sign if anyone can do this. Yeah, brilliant. If anyone here is able to help, that would be tremendous. We don't want these guidelines being too hospital orientated. Okay, I'll see if there's any other. I've got a huge document here of our action plan and things that we're working through. Carrie Luna sat on an NHS Scotland panel discussing health inequalities and climate. Climate sustainability are being discussed regularly with MSPs. There's been a Scottish Academy climate statement, which we've been instrumental in. We've raised general practice premises in discussion with Cabinet Secretary, which is resulting in this meeting. What else? It's just, yeah, it's become part of all college meetings. So that's some other things ongoing. The biggest bit of work was the response to the NHS sustainability strategy, because that's got levers to really make things happen, hopefully. So there's going to be 3 more of these talks. I guess please give feedback as to what would be most useful for you, because this one's probably geared more at people who are maybe not already active in the area, because you might know a lot of the stuff I've spoken about, but all of them will be opportunities to have discussions, do a bit of troubleshooting, feedback, what you want the college to work on, and as Deepa pointed out, to share what's already happening, because we've already been able to share quite a lot of things here as to what other solutions people have found. So yeah, I've gone through some of my favourite bits of information there. It's been great to hear from you and about things that are ongoing. Often there's examples of folk who are way ahead, which is really great to hear. Especially excited about James Morton's homemade cargo bike. That sounds great. Sounds a lot cheaper than mine. So yeah, unless there's any other questions or comments, I'll thank you all for coming along and getting involved. Really nice to chat to you, and get in touch, and I'll see you soon.